Hello and welcome to this video brought to you by Atoza. Thanks for subscribing to these talks. My name's Garth. This is the first of 3 videos focusing on the airway, and in this first video we are going to be looking at airway assessment, planning and preparation. In the second and third videos we will look at the technical aspects of airway management and the vortex model for airway management. Airway management is a huge topic in anesthesia, and one in which we will never stop learning, either by refining our understanding or by gaining more practical experience. In preparing for this tutorial, I certainly have benefited greatly by revisiting the foundations. To be honest, I've also had flashbacks of when I have found myself in an anticipated and an unanticipated difficult airway scenario. And I realize how lucky I am that none of them have ended in disaster. After such reflection, I am struck with the following key points. Firstly, anesthesia-trained doctors are likely to be the most competent airway technicians in the hospital, especially at night. That's a really big responsibility. Secondly, airway complications are common, and they can be life-threatening, and they can happen even when unexpected. As anesthetists, we talk about the anticipated difficult airway, the unanticipated difficult airway, and then other causes of acute airway difficulty, which may include vomiting and aspiration, acute bronchospasm, and anaphylaxis, just to name a few. Thirdly, we as anesthetists can be responsible for turning a difficult but safe airway into an impossible, maybe fatal airway complication. Our decisions and actions matter. That can all sound pretty terrifying. So how do we make airway management safer? Well, there are a few points that I can think of and that we will cover in detail during this talk. Firstly, by planning and preparing, which includes the airway assessment, preparing the airway trolley with routine airway equipment, preparing the advanced airway equipment or the emergency airway equipment, then having support available, such as a more experienced colleague, adopting a 2-person airway breathing technique, or having surgical support for an emergency surgical airway should the need arise. From this, it must be obvious that excellent communication is paramount. We need to have excellent communication between the anesthetist and the anesthetic nurse or assistant, because they are the team that are actually tackling the airway. But we mustn't forget that we also need excellent communication between the anesthetist and the whole surgical team. And lastly, we can make airway management safer by understanding and following an algorithm or airway management model. 2 excellent examples of such algorithms or models are the Difficult Airway Society guidelines, called the DAS guidelines. These are excellent for conceptual understanding and for planning. And another example is the vortex model, which is an excellent practical clinical approach and one that we will go into more detail in this series. If you are quite new to anesthesia, you may be asking, but what is it that makes an airway difficult? Airways may be considered difficult for a few reasons. I group these reasons in 3 sections. Firstly, the anatomical characteristics of the airway, which will be discussed in detail in this talk. Secondly, the physiological characteristics of the patient, which may include if the patient is likely to be a rapid desaturator because they have a low functional residual capacity. We will talk more about functional residual capacity in the talk on ventilation, but it basically refers to a low reserve oxygen in the lungs, and this may include obese patients, pregnant patients, or any patient with abdominal distension. Rapid desaturation may also occur due to increased metabolic requirements, and rapid oxygen depletion. And examples of this would include pediatric patients, burns patients, septic patients. Another physiological consideration is unstable patients that can't tolerate even brief periods of desaturation or hypercapnia. Lastly, there are environmental factors that may make airway management difficult, which usually includes all airway management outside the theatre, where equipment and support may be less than ideal. Let's look now at addressing some of the anatomical factors that make an airway easy or difficult by jumping into the clinical airway assessment. There are about 11 different anatomical factors that one looks at in a complete airway assessment. Let's start with the nose. We want to look at the size and shape of the nose, as this can affect the placement of a mask on the face and the ability to get a seal from that mask. And we also want to look at nostril patency. Can the patient breathe through each nostril? We can then look at the patient's facial hair. Having a lot of facial hair affects mask seal. We then have a close look at the teeth, and we want to look at the angles of the teeth, whether they are angling forward, whether there are gaps between the teeth, whether there are loose teeth, teeth that have chips, teeth with severe dental caries that may chip or break during airway management, whether there are false teeth or crowns, and make note of any teeth that are missing. It's not a nice feeling when you finish with a difficult intubation and you look down at the teeth and their teeth missing, and you wonder, have I knocked out one of these teeth, or was this tooth missing from the beginning? So one wants to pay very careful attention to the teeth and actually document on your anesthetic chart where the problem teeth are, so that one knows how best to take care of those teeth, and also if there are complications, that one has a reference point to go back to after the case. The next point is to look at mouth opening. And mouth opening is really about being able to fit the airway equipment into the mouth, and also to be able to maneuver that airway equipment adequately. And ideally, in an adult, what we want is a mouth that opens at least 3 centimeters. So the gap between the incisors to be at least 3 centimeters, or one can say 3 finger breadths. So it's actually quite difficult for me to get 3 fingers into my mouth. But I do know that I am an easy airway because I've had a few anesthetics myself. Anyway, then we can look at some distances. So the first measured distance is called the sternomental distance, and it's from the notch of the sternum to the tip of the chin. And ideally, we want that distance to be at least 13.5 centimeters. And to some extent, it's actually a measurement of neck length, but also neck extension. The next distance that we're interested in, and this is the one that I particularly feel is valuable, is the thyromental distance, which is the distance from the thyroid cartilage, again, to the tip of the chin. And we want that distance to be at least 6.5 centimeters. And it reflects the amount of space in the floor of the mouth for when we're doing laryngoscopy, and we're not pushing the tongue into the floor of the mouth, we are moving it sort of leftwards laterally, and that sort of gives you an idea of how much space there is for that maneuver during laryngoscopy. So I think it's a very good indicator of whether you're going to be successful or not during laryngoscopy. The thyromental distance, and we want it to be at least 6.5 centimeters. Another thing to assess is how much the patient can protrude their jaw, or whether the jaw is in an abnormal position of protrusion to start with. So what we can see is we can see significant underbites, and we can see significant overbites, where the alignment of the top incisors and bottom incisors is not where it normally is, and there's a big gap between the incisors in an anterior-posterior direction. So whether that exists to start with, but then also on movement, how much movement there is in the jaw. And one of the classic indicators of a difficult laryngoscopy is patients that have small mandibles that are receded, and that obviously progresses all the way through to the term, which is called micrognathia, which is patients that have particularly small mandibles, and that's well known to be a sign of difficult laryngoscopy. Next, we can have a look at neck extension. And if one really wants to assess neck extension accurately, rather than just saying to the patient, can you extend or can you tilt your head backwards, which in the bed they can use their upper body and their torso and their spine, and it's actually quite difficult to tell which part of them is moving, is to place your one finger on the patient's chin and your other finger on the patient's occiput, actually get them to extend like that. And in that position, you can then get a feeling for how much movement has happened between the chin and the occiput. And ideally, full extension means that the levels sort of level out, or perhaps even your chin is slightly higher than the position of the occiput. And an inability to extend the neck is, again, a feature of difficult laryngoscopy. One must also look at the hairstyle of the patient, and in particular, whether there's occipital hair buns or bobs or ponies or dreadlocks that are bunched up in the occipital area, because those will significantly affect neck extension. And when you are assessing the patient sitting up in their bed or at 45 degrees in their bed, they can still do that neck movement, but when they're lying supine on the operating table with a pillow behind their head, that occipital hair will significantly impair their neck movements. The solution here is to either get the patient to undo the bun or to spread their hair out before they come to theatre, so that when you position them on the operating table, the hair isn't all accumulated behind the occiput. The other option is to use a number of pillows under the shoulders so that you can position the airway with the neck extended and the chin slightly forward. Part of the anatomical airway assessment also includes examining the front of the neck. As we will see in the second airway talk, front of neck access and emergency surgical airway is the final step in the can't intubate, can't ventilate algorithm. And so for every patient, one needs to have an idea of how easy it is to perform an emergency surgical airway. And this requires examination of the front of the neck. And what we are feeling for is the thyroid cartilage, and we are feeling for the cricoid ring, and then the membrane that is between those two cartilages, which is called the cricothyroid membrane. And that's what we're going to access for our emergency surgical airway, and we'll cover that in some more detail in the second talk. Lastly, but probably the most well-known airway assessment, is the Mallampati score, and combines an assessment of mouth opening and the amount of space between the tongue and the hard palate and soft palate, and it's linked to ease of laryngoscopy. So if you have a look at the picture, it's a score involving 4 different grades. So you ask the patient to open their mouth, stick out their tongue, and we are looking to see how much of the hard and soft palate and uvula can be seen. So in a grade 1 view, one can see the hard palate, the soft palate, and the whole uvula, so there's lots of space. In a grade 2 view, we can see the whole of the hard palate, the whole of the soft palate, and we can see most of the uvula. And grade 1 and grade 2 views are associated with an easier laryngoscopy. And then a grade 3 view, we can see the hard palate, but one can only see a portion of the soft palate. The tongue is obscuring the rest of the soft palate. And then in a grade 4 view, one cannot see the soft palate at all. One can only see a portion of the hard palate. And grade 3 and grade 4 views are associated with a more difficult laryngoscopy, a more difficult airway. So those are the anatomical characteristics that we look at during a clinical airway assessment. But our clinical airway assessment must also include the physiological factors that make an airway difficult or easy to manage. So firstly, looking at the respiratory system, obviously we examine the respiratory system of all of our patients for a number of reasons, not just airway assessment. We examine them to assess their respiratory reserve, to assess perhaps the best mode of anesthesia. Maybe we want to avoid a general anesthetic completely and do a regional technique on patients with severe respiratory problems. We examine them to assess the post-operative care that might be needed, if there's any optimization that might be required, such as bronchodilators or steroids or treatment of infection. So there's a number of reasons that we do a full respiratory examination.
For the purposes of this tutorial, because we are focusing on airway management, I want to draw your attention specifically to two aspects of our respiratory assessment. Firstly, how our airway management is going to affect the lungs. And this could include things like the risk of bronchospasm, the risk of introducing infection into the lungs if our sterile technique during intubation isn't good, the risk of inducing lung injury, the risk of inducing atelectasis or alveolar collapse during our airway management, especially if we struggle with airway management and there is a prolonged period of hypoventilation or ventilation without PEEP. When using supraglottic airways in particular, we need to be conscious that we may not be able to apply more than 5 centimeters of PEEP, and then sometimes even 5 centimeters of PEEP will result in a leak. And so for patients who are at risk or longer surgeries, using supraglottic airways can lead to atelectasis. And then secondly is to consider how the patient's respiratory function is going to affect airway management in terms of their speed of desaturation. And what we are particularly worried about is patients that are rapid desaturators. And from a respiratory point of view, that can either be because they have small lung volumes or a low functional residual capacity. And so they have a lower reserve of oxygen within the lungs when they become apneic. And so they will desaturate more rapidly. And this can be patients with chronic lung damage that's affected the parenchyma of their lungs. It can be patients with chest wall abnormalities in small lungs, and then any patient with raised intra-abdominal pressure, such as obese patients or pregnant patients or patients with bowel obstruction, are going to have small lung volumes because of the abdominal pressure pushing up on the diaphragms. There are also other patients who may desaturate rapidly, and these could be patients with diffusion abnormalities, such as infections in the lung or pulmonary edema that affect the ability of oxygen to diffuse into the blood. And then patients who have got shunt may be hypoxemic from the start, but they will also desaturate more rapidly. And there are lots of causes of shunt, such as atelectasis, pulmonary emboli, infection, pulmonary edema, and then also cardiac causes of shunt. So the question we're really asking is, what airway technique is best for this patient's respiratory system? And then also, are these patients at risk of desaturating quickly? The same applies with the cardiovascular system. We do a cardiovascular system assessment for all of our patients for a number of reasons. But in particular, when thinking about airway management, there's two questions we want to ask. Firstly, how is our airway management going to affect the cardiovascular system? And this is normally in terms of managing intubation and extubation responses. And we'll talk about this in a bit more detail in the next airway talks and then also in the talks on intravenous induction drugs. But for example, inserting a supraglottic airway in a patient where you are trying to balance cardiovascular stability and the risk of hypotension can be extremely difficult, and I would advise against that. And then also managing intubation and extubation responses can be a challenge too. And intubation and extubation carry the risk of tachycardia and hypertension, and that could be poorly tolerated in patients with ischemic heart disease, in patients with arrhythmias, and in patients with heart failure. Another condition that is quite sensitive to our airway management is that of pulmonary hypertension, and in moderate to severe pulmonary hypertension, we have to avoid hypoxemia and we have to avoid hypercapnia. Otherwise, that can precipitate worsening pulmonary hypertension and acute right heart failure. So that is a condition that we have to be very mindful of while we're managing the airway. Moving on from the cardiorespiratory system, we also need to assess the metabolic physiological status of the patient. Patients who are shocked and have metabolic acidosis will tolerate periods of apnea poorly because apnea will result in hypercapnia, and then one can get a respiratory acidosis on top of a metabolic acidosis, and that could precipitate arrhythmias or full cardiac arrest. And so we have to manage the airway differently in those patients. And then also patients who have a high metabolic rate, such as septic patients, burn patients, pregnant patients. Their oxygen consumption is much higher, their cardiac output is higher, and so they are going to desaturate more rapidly. And then we need to move on to assess the abdominal system. And really here what we're assessing is the risk of aspiration of gastric contents during airway management or during the surgery. And in the next airway talks, I go into how to assess aspiration risk. And then we also need to remember, like I've said, the effect of raised intra-abdominal pressure on functional residual capacity, the risk of atelectasis, and then rapid desaturation. And then lastly, neurological function can also affect our airway management, in that patients with severe neurological disease may be more prone to apnea, they may be more prone to regurgitation and aspiration of gastric contents. Certain patients may not tolerate a face mask, and it may be difficult to pre-oxygenate them, for example, acutely confused patients. And so the neurological system can also affect airway management. So really, as with many things in medicine, airway management doesn't stand alone. It can be affected by almost all the organ systems and many, many disease processes. And so when we're assessing these patients preoperatively, we can't just focus on the anatomical assessment of the airway, but we need to look at the patient globally.
Right. So, having completed a good airway assessment, we are then in a position to make an airway plan. The best approach to this, I feel, is to ask oneself a series of questions. Firstly, beginning with the most simple form of airway management. Is mask ventilation going to be difficult? So that means, is it going to be difficult with an external mask on the patient's face to manually breathe for the patient using a bag mask technique? Next, is laryngoscopy going to be difficult? So this question is asking, is it going to be difficult to insert a laryngoscope into the patient's airway and advance that laryngoscope down the airway and get an adequate view of the vocal cords? Next question, is intubation going to be difficult? So now, having got our laryngoscope into the best position that we can get it into, is it going to be difficult to actually intubate the trachea? And those are two steps. And with experience, you'll see why the distinction is made, because it is possible to get a reasonably good view of the vocal cords with a laryngoscope, but have difficulty in getting the endotracheal tube through the vocal cords. The most common example of this is where the airway is very anterior, and it's difficult to advance your tube in that anterior direction towards the vocal cords. But there are other causes of that too, in distorted airways and airways with abnormal anatomy due to mass effects or fibrous tissue or scarring that's pulling the airway in different directions, all the way through to edema of the vocal cords, growths and tumors on the vocal cords. So there's a lot of things that can contribute to difficult intubation, even if your laryngoscopy has been easy. Next question. Is the use of a supraglottic airway likely to be difficult? And is a front of neck rescue surgical airway going to be difficult? These 5 questions form the foundation of airway planning and management. And it's essential to ask and answer all 5 questions, irrespective of what your planned airway management is. That is because our first plan may not work. And so, for example, if we are intending to use a supraglottic airway and it fails, we will then have to rely on the other airway management techniques, which we may not have expected to do. So that's why we need to ask all 5 questions. If the answer is the step will be difficult, then we cannot rely on that mode of airway management. And as more answers turn out to be, yes, this may be difficult, then the more dangerous and challenging the airway becomes. In addition to these 5 questions, we also need to ask for all patients, is this patient an aspiration risk? Is this patient likely to desaturate rapidly? And how will this patient handle airway management physiologically? Most of the above teaching of airway assessment and management predates the availability of video laryngoscopes. It's still entirely clinically relevant though. But you may ask, how do video laryngoscopes change this teaching? There is no doubt that video laryngoscopy has made airway management safer and faster. It has also reduced the need for awake airway techniques. I certainly have been lucky that since the beginning of my anesthetic training, video laryngoscopes have been available, and I really don't know how anesthetists managed practically and also from a stress point of view without video laryngoscopes. Video laryngoscopy, though, is not a perfect technique. There's still some concerns with this approach. These concerns are, in some patients, it may still be difficult to insert the video laryngoscope, such as patients with significantly reduced mouth opening, or obese patients, or patients with cervical spine pathology, such as trauma patients where they're wearing a hard collar. Patient positioning is still important to allow mouth opening, and also so that the handle of the video laryngoscope doesn't get stuck against the chest while one's trying to insert the scope. Video laryngoscopy can result in improved laryngoscopy, but we can still face difficult intubation. And there have been numerous studies trying to look at the reported rate of needing to use a bougie or a fiber optic camera to assist intubation during video laryngoscopy. In other words, it may be easy to see the vocal cords, but not easy to pass the endotracheal tube through the vocal cords. Malfunction of this electronic device is something that can happen at any time. We definitely need to check that the video laryngoscope is working before we use it, but I've had cases where I've checked the scope and the screen and everything has looked like it's working adequately, and I've inserted the video laryngoscope into the airway and suddenly there's been a malfunction and I can see nothing. That's not a great situation to be in. And lastly, I'm yet to work in a theatre complex with a video laryngoscope in each theatre, so the device isn't always available when you need it. Someone else might be using it for an elective intubation, where they planned on using it from the beginning, or someone might have called for it in an emergency situation, and then when you need it at the same time in your emergency situation, it's not available. So going back to the questions we had to ask ourselves to decide how best to manage each airway. There are mnemonics available to assess the ease of each task, and we'll go through these now. Firstly, is bag mask ventilation going to be difficult? The mnemonic is MOANS. M-O-A-N-S. The M stands for mask seal. Anything that can affect mask seal. This includes a large prominent nose, lots of facial hair, burns to the face, distorted anatomy of the face. The O stands for obesity or obstruction. Things that obstruct the airway, such as soft tissue from obesity, swelling of soft tissue and angioedema or infection or hematoma. And we know that pregnancy can cause edema of the airways and can also cause obstruction of the upper airways. Age, it's said that patients older than 55 may be more difficult to mask ventilate. The N stands for no teeth. And the teeth actually contribute significantly to the anatomy and the structure of the mouth and the upper airway. And for this reason, in patients that have got dentures, I always leave the dentures in at the beginning of my anesthetic. Once the patient is asleep, I check the ease of mask ventilation, and if everything is going well, I remove the dentures before I intubate so that I can protect the dentures from damage during intubation. I then obviously keep the dentures safe for the patient during the anesthetic. The S stands for sleep apnea or stiff lungs. So in sleep apnea, we know that when the patient goes to sleep and they lose some of their airway tone, that the movement of air through the upper airways is obstructed. So sleep apnea tells us that we're going to have difficulty with external positive pressure ventilation in the form of mask ventilation. Stiff lungs, well, that means that if it's difficult to blow air into the lungs, it's going to be difficult to use any form of supraglottic airway or mask ventilation. And this includes things like asthma, emphysema, ARDS, or severe lung infections. The next question is a supraglottic airway going to be difficult to use? And the mnemonic here is RODS, R-O-D-S. The R stands for reduced mouth opening. The mouth has to open enough to insert the supraglottic airway. And there's quite a few different types of supraglottic airways, and they have different diameters or sizes, and some lend themselves to going into smaller airways, whereas other ones are quite big or chunky and are a bit more difficult to insert if there is reduced mouth opening. The O stands for upper airway obstruction, and again, that includes angioedema, infection, hematoma, obesity, pregnancy, anything that results in swelling of the tissues of the upper airway. The D stands for distorted airway, and this is more mechanical distortion where the anatomical position of things is moved. The supraglottic airways are designed to fit into an airway of a particular shape, and so if there's distortion, they may not work. The S stands for stiff lungs again, and here the same examples apply: COPD, asthma, ARDS, and indirect stiffness of the lungs occurs in abdominal distension because there's extrinsic compression on the thoracic cavity, and that can result in a similar situation to stiff lungs. The next question is intubation going to be difficult? And the mnemonic here is LEMON, L-E-M-O-N. The L stands for look externally, and this is very similar to our clinical airway assessment. So looking at external aspects of the airway, the size of the chin, the size of the mouth, and the ability to move the mandible. E stands for evaluate, and again, this is anatomical clinical assessment. Evaluate mouth opening, environmental distance, and one could include here all of the aspects of clinical airway assessment. The M stands for Mallampati score, and again, we went through that earlier, where a score of 1 or 2 suggests that intubation is going to be easier, and a score of 3 or 4 suggests that intubation may be difficult. The O stands for obesity, and as you can see, obesity is coming up in all of the difficult airway situations. The O also stands for obstruction of the airway, and features of airway obstruction include stridor, drooling, sensation of choking, soft voice. The N stands for neck immobility, and here what we're looking at is the ability to extend the neck, and as you remember, we went through how to accurately assess neck extension. The next mnemonic is for the question, is a surgical front of neck cricothyroidotomy going to be difficult? And here the mnemonic is SHORT, S-H-O-R-T. The S stands for surgery to the neck. The H stands for hematoma. The O stands for obesity. The R stands for radiation to the neck. And the T stands for tumor. And these are all factors that result in altered anatomy, altered quality of the tissue, a distortion of the anatomy, and those are all things that are going to make it difficult to find the cricothyroid membrane, to cut through the tissue, to separate it, and to actually insert the surgical airway. If you are new to anesthesia, it may be worthwhile writing down these mnemonics on some cheat cards and keeping them with you in theatre and in your pocket when you go to the wards to do your pre-anesthetic assessments, so that you can accurately answer these questions and so that you get used to what the mnemonics stand for and making sure that you adequately assess each airway before you bring the case to theatre. It's also really useful to actually answer the question, do I think it's going to be easy? And then check whether you were right or wrong, and then reflect on where you might have gone wrong in your assessment. So you might have thought that mask ventilation was going to be easy and it turned out to be difficult. And then afterwards to actually look at the airway again and look at your assessment and to think, how can I learn from what happened here? Right, so we're moving slowly closer to actually being able to tackle and manage an airway. Let's look at the equipment that should be present on the standard airway trolley in theatre. So the first and possibly the most important piece of equipment is the ambu bag with oxygen connecting hosing. The ambu bag is the rescue breathing apparatus that we're going to use if there's equipment failure or malfunction with the circle system, with the anesthetic workstation, with the ventilator. And we have to make sure it's 100% essential that we have a working ambu bag, and we'll go through how to check the ambu bag to make sure it's working properly
in the talk on improving safety in theatre.
The next thing we need is a Yankauer suction nozzle, which is a rigid plastic suction nozzle that's got a slight bend to it or curve to it so that we can suction the airway. And that's because saliva or blood or other foreign materials such as vomit can easily obstruct our view and impede our management of the airway. And if we don't remove secretions and liquids, we run the risk of blowing those into the lungs and causing problems there. We then need ventilation masks of varying sizes, and we can test the mask on the patient's face to choose the most appropriate size. We need something to lubricate our airways and our airway equipment so that it's got less chance of causing abrasions, scratching, bleeding, and edema to the airway as we put it in. We need a metal introducer or stylet that we can put inside the endotracheal tube to give it a preformed shape to aid intubation. And the classic one is trying to bend the endotracheal tube so that it can access more anterior larynxes. A plastic gum elastic bougie is also essential in my opinion. I use a gum elastic bougie frequently in theatre, and this enables us again to bend the bougie and manipulate it within the airway, pass it through the vocal cords into the trachea, and then railroad an endotracheal tube into the trachea. We need some form of strapping for the airway, and there are a few options available. And the type of strapping that you use might depend on your personal preference, but it also might depend on the risks with that airway. So if you're turning someone into a prone position on a fancy operating table for operating on the lumbar spine, then you want to make sure that that airway is really secured. Whereas if the patient is lying supine with an LMA in place, then you could probably use some simpler strapping to secure that airway. We need to have a McGill's forceps, which is a curved forceps for grabbing objects. And for the first few months of my anesthetic training, I looked at this piece of equipment and wondered why it was even on the airway trolley. But I have used it a number of times since then. So firstly, for nasal intubations, it's an absolute must, so that once the tube is advanced through the nose into the pharynx, one can then perform laryngoscopy and grab the tube with the McGill's forceps and direct it between the vocal cords. But it's also excellent at removing foreign objects from the airway. And I've had to remove a few foreign objects before. And two examples that I can think of is obviously if someone has vomited and there's particulate matter above the vocal cords, such as carrot. There always seems to be carrot in vomit, or chunks of meat. We can grab that and remove those foreign bodies. But I once anesthetized a trauma patient who had obviously hidden his SIM cards, 2 SIM cards, in his mouth when he came to hospital so that he wouldn't lose his important information on his SIM cards. And I didn't see them during my airway assessment. And when I put the patient to sleep, those SIM cards slid down the back of the airway and were actually lying on top of the vocal cords. And I then grabbed them with the McGill's and removed them, which was quite fortuitous. So McGill's forceps are a must-have. We also need an artery clip, and I use this to secure or clip the breathing circuits to the patient's bed, either to the pillow or the blanket, so that the weight of the breathing circuits is not pulling directly on the airway. The weight of the breathing circuits is supported by the artery clip attached to the bed, and the airway is not under any traction. We need endotracheal tubes of appropriate sizes, and normally we have 3 different endotracheal tubes, the size you think you're going to use, and half a size smaller and half a size bigger.
We need a puffer syringe to inflate the cuff of the airway, either the endotracheal tube or the supraglottic airway.
We need 2 working laryngoscopes on our airway trolley, and ideally these laryngoscopes should be of a different size. So the classic would be to have a size 3 and a size 4 Macintosh blade, but you could also have them of a different type. So you could have a McCoy blade and a Macintosh blade, or a video laryngoscope and a normal laryngoscope. We need to have supraglottic airways on our airway trolley, not just because the supraglottic airway might be your primary airway device for that case, but also to have it there as a rescue airway option if we're struggling with intubation and mask ventilation. We need to have nasopharyngeal and oropharyngeal airways of appropriate sizes on the airway trolley to aid in mask ventilation, and also perhaps to aid at extubation if we're worried about upper airway obstruction. So those are the pieces of equipment that we have on the standard airway trolley. And again, it's not worth compromising, it's not worth taking a chance. When you start the day in your theatre or you start your slate, check all the equipment, make sure that it's there, and then for the rest of the day, you know that if you get into trouble, what you need is going to be present. So let's focus now on each piece of airway equipment, and I'll go through how and when I use it, and perhaps some of the subtleties that you might not have thought of. So talking about laryngoscopes, the Macintosh laryngoscope is a gentle curved laryngoscope. I routinely use a size 4 for adult males, and I routinely use the size 3 blade for adult females. Laryngoscopes also come with a McCoy blade, which is useful in cases where we anticipate an anterior larynx, or where we've performed laryngoscopy with a standard laryngoscope and the larynx is quite anterior. Because with the McCoy blade, we're able to flex the tip of the laryngoscope when it's in the vallecula, and that can just help lift the epiglottis and show more of the vocal cords during our laryngoscopy, and can aid in intubation. I seldom use this piece of equipment. I find it quite difficult to be moving the laryngoscope in the correct direction and squeezing the apparatus to cause the tip to flex, and then not touching the teeth or fulcruming on the teeth. And I virtually replaced its use in my practice with video laryngoscopy. But I do end up using the McCoy blade from time to time because, as I've said, video laryngoscopes are not always available. And then I have to pay real careful attention to not damaging the teeth while I'm using this piece of equipment. I'm also a little bit concerned about causing more airway pain and trauma because of that extra manipulation on the epiglottis and the larynx. Next, looking at video laryngoscopes. Video laryngoscopes come with the standard Macintosh blades, and they also come with a difficult airway blade, which can be called a D blade in some of the devices, and it's got a more significant curve, and that's so that the blade can get into more anterior larynx positions. And I actually routinely use the D blade when I'm doing video laryngoscopy, and I do so with a pre-curved introducer or with a bougie. And because I routinely use the D blade, I've got myself into a comfortable and confident position where I know how to manipulate the stylet of my endotracheal tube or how to manipulate the bougie so that I can get the bougie into the larynx. As I've said, one of the challenges with video laryngoscopy is you can get a fantastic view of the vocal cords on the screen, but not be able to get the tube through the vocal cords. And by using the D blade every time I'm doing a video laryngoscopy, my exposure rate is quite high, and it gives me the opportunity to stay slick with how to bend the bougie or bend the tube to get it into the right place.
There have actually been quite a few publications, if you do a literature search, on the different ways of using a stylet or a bougie to aid your intubation when you're using a video laryngoscope, and specifically the extra curved difficult airway blade or D blade. Firstly, this reference, which is from the Canadian Journal of Anesthesia, where it talks about using the guide rail of the D blade as a channel for the gum elastic bougie during intubation. So the picture on the left shows how the gum elastic bougie has been curved to have a similar curve as the blade of the laryngoscope. And then the picture of the right shows the epiglottis and the arytenoids, and then the bougie approaching the airway for intubation of the larynx with the bougie first. And then they are obviously going to railroad an endotracheal tube in. So this is very similar to my technique. I tend to prefer to use a gum elastic bougie to aid intubation. The second reference is from the Brazilian Journal of Anesthesiology, and this is an article where they look at comparing different stylets and different angulations of the stylet and therefore the tube to aid video laryngoscopy and intubation with the D blade. And I think it's quite a cool picture because it shows you the different options in terms of how far one wants to angle the tube, and then using preformed stylets or malleable stylets or gum elastic bougies. And I think for me, in my practice, when I have used a stylet, I've tended to go with the bottom left picture where I preform my stylet and endotracheal tube to match the curvature of the D blade. And then I follow the curvature of the D blade with my tube while I'm inserting it, and hope then that the tip of the tube is going to end up at the vocal cords.
Next, we can look at supraglottic airways. So supraglottic airways allow for spontaneous ventilation or for positive pressure ventilation at a level above the vocal cords, and they're inserted deeper than a Goodell airway to the back of the pharynx and all the way down to sit above the epiglottis and above the vocal cords. The first generation devices are relatively simple, and they only allow for ventilation. An example is the LMA Unique. The second generation devices incorporate a suction passage that one can suction down to remove secretions from the lower pharynx. One can also insert a nasogastric tube down that passage into the stomach and decompress the stomach. And the second generation devices normally also have a bite block, so that if the patient does bite on the airway, they don't compress the breathing tube completely. And examples of these could be an iGel or an LMA Supreme. If we look at oropharyngeal airways, so these are hard plastic devices that are aimed to insert mostly into the proximal upper airway. They go in through the mouth and sit just behind the tongue as starting to curve down to the hypopharynx. I often use these devices at induction of anesthesia to aid bag mask ventilation. Inserting the appropriate size is important, and we can measure the size from the angle of the mouth to the meatus of the ear, and that should be the correct size to insert for the patient. I never use these devices at extubation because of the risk of dental damage if the patient bites on them. These are not bite blocks. They're not designed to protect your endotracheal tube from being bitten. They are there to aid you with mask ventilation. And it only takes one patient with bad teeth at extubation to bite down on that hard plastic airway with their bad incisors and shatter the incisors for you to never want to use it again at extubation. So bite blocks, those are things that we put over in the lateral aspect of the mouth between the molars, and then when the patient bites, they're biting on their stronger molars. They're not biting on their incisors. So the other option other than oropharyngeal airways are nasopharyngeal airways. And these are soft devices that can be inserted through the nostrils, down the back of the nose, and again into the pharynx. And I often use these devices, but I use these devices at extubation, and I use them if I'm worried about upper airway obstruction after extubation. So the classic one would be in obese patients or patients that I know have sleep apnea, and I know that while they're waking up and they still don't have full return of their airway muscle tone, that they might obstruct. And so I can put in a nasopharyngeal airway and then extubate the patient, and the patient hopefully then can breathe smoothly and freely through that nasopharyngeal airway. Lubrication is really important, and one can also spray some vasoconstrictor drops down the nasal passages first so that you don't cause bleeding when you insert them. Sizing of the nasopharyngeal airway is important, and here we measure it from the nares of the nose again to the meatus of the ear. So then looking at the malleable stylets or introducers for our endotracheal tube. So as I've said, I frequently use these during video laryngoscopy to preform my endotracheal tube. The other place where I routinely use it is in rapid sequence intubations, where I'm worried about regurgitation and aspiration, and I want to make sure that my first attempt at intubation here is successful so that I can secure the airway and protect it from any reflux or vomiting. And so my rapid sequence intubation technique routinely involves a stylet in the endotracheal tube. You have to lubricate the stylet so that it's easy to remove from the tube once the tube is in the correct position. The gum elastic bougie, we've gone through this already. I regularly use this device. I use it during routine intubation when I only have a partial view of the vocal cords, and then I can use the bougie to lift up the epiglottis and pass between the vocal cords and then railroad my endotracheal tube in. Or I use it if I'm doing video laryngoscopy with the D blade and the larynx is anterior and I'm struggling to get my tube to advance into that anterior position. Then I can curve the bougie and use that to intubate the airway first and then railroad in an endotracheal tube. In addition to our standard airway trolley that we've just gone through in some detail, your theatre complex also needs to have emergency airway equipment and or a difficult airway trolley. And this may have some of the standard airway equipment on it to cover any deficits that might be in the theatre or in the recovery room. But one of the main features is having a surgical cricothyroidotomy set so that in an emergency situation, you can call for that set and you can rapidly perform your surgical airway. And that set should have a scalpel, ideally a size 10 blade, a bougie, and a size 6 cuffed endotracheal tube. So there we go. We have gone through all of the content for this first talk on airway assessment, planning, and management. And in the second talk, we'll be putting some of this knowledge now into application and talking about more of the clinical aspects of airway management itself. Thank you for listening, and I hope you enjoy the next talk.